Good morning, everyone. Thank you. All right, your turn. See if you can get a response.
All right, let me try. Good morning, everyone. All right.
All right, much better. Next time she's going first. Well, good morning and welcome to the CMS 2018 Medicare Advantage and Prescription Drug Plan Audit and Enforcement Conference. My name is Stacy Plizga, if you weren't here yesterday, and this is?
I'm Kay Rabel.
And we will be co-moderating the conference today. Before we get started, I'm going to go ahead and turn it over to Kay.
All right, we're going to review a few logistical items this morning. Continuing education credits, including CCB and CMSE credits, are available for today's event. You can find this information it's located in the conference guide as well as on the CTEO website. Webcast materials are available on the CTEO website, listed on the link on the screen, as well as on hashtag CTEOCon on Twitter. If you have not already done so, you can log on to the site and obtain the presentation materials and follow along with our presenters today. If you experience any technical difficulties, we have staff members available to assist you. Please use the email box cteo.techsupport@cms.hhs.gov for any technical question or concern. Please remember that if you use Internet Explorer as well as a Ethernet connection, you may experience increased webcast streaming speeds to prevent delays.
The Medicare Advantage and Prescription Drug Plan Audit Conference and webcast will feature interactive polling today during the sessions and also for end-of-session evaluations to allow both our in-house guests and our virtual audience a chance to participate throughout the event. There are a number of ways that you can participate. You can respond to the polling questions from any mobile phone by sending a text message, or you can respond by any smartphone, computer, iPad, or tablet by visiting the Poll Everywhere web address. There we go. If you would like to participate utilizing your cell phone, you must first join our session for today. So let's go ahead and do that together. So if you have your cell phone handy, please get it out. Virtual and in-house guests. And to join via text messaging, you are going to select the text message screen. In the to box, you will type in the numbers 22333. And then once you do that, in the message box, you are going to type in the letters and numbers CMS 2018 Audit. This is not case sensitive, but please do not put any spaces in between the letters and numbers. Once you have done that, you can go ahead and send your message. You should receive a response back saying that you have joined the CMS 2018 session. If you did not get that message, then please try again. It just means you had a typo. This session will remain open throughout the conference, so you will not need to do this again. Okay, for entering your responses, to enter your response, each time a poll is conducted, you will simply type in the letter that corresponds to your answer and hit send. It's as easy as that. We also have end-of-session evaluation questions, and these are a little different, so we'll go over some instructions for those. So when you are prompted by the moderator, you are going to enter the letter A in the message box to respond to the question, I would like to evaluate this session. You will then receive a text back that says, hello, please evaluate this session, and it'll provide a link for you. Go ahead and click on that link. It will then take you to a number of questions that will appear one by one. You will select your answer, and then you will select next. And then you will get your your second, third, and fourth question, and finally, after the fourth one, you will see the word finish, and when you hit finish, it will submit your responses.
Okay. If you would rather join Poll Everywhere via your computer, tablet, smartphone, using your web browser, you must first join our session. To do this, go to www.pollev.com/CMS 2018 Audit. You will see a page like the one on the screen. This means that the poll is not in session. The polling questions will appear when prompted by the moderator at the end of the session. To enter your response via web browser, when the questions appear, click on your answer choice. Right? When prompted by the moderator, go ahead and choose yes in response to the question, I would like to evaluate this session, and you will be presented with the link to evaluate the session. On this link, it will appear in a green box at the top. When the next screen appears, choose Start Survey, and you will be presented with the evaluation questions one at a time. Select your answer and click Next to advance to each question, and then submit your response by choosing Finish.
All right, so we're going to give this a try this morning, and this may look familiar to some of you, but we still want to know how you're feeling today. So go ahead and select your response to which emoji best represents your morning. All right, while you are answering this, you will see that the results are coming in, and you'll see the bars that are going up and down. They're being calculated. So this is how it will look throughout the day. So you'll get to see the percentage of responses. So we're going to see how you guys responded today. Oh, very similar to yesterday. We have a lot of happy people here today, so glad to see that.
Okay. And earlier, I misspoke for our webcast participants. To increase your streaming speed, you're going to want to use Chrome instead of Internet Explorer with your Ethernet connection. And we look forward to everyone's participation in today's event. For our webcast participants, if you have a presentation-related question, we would ask that you go to the SurveyMonkey link that was found in this morning, that was sent to you this morning with the polling instructions, and go ahead and enter your question as well as your contact information there. We will either answer your question today during the event, or we will answer, it will be answered by your SMEs and posted on the CTO webpage at a later date. For our in-house participants, we ask that you address your questions using the microphone in the center of the room. That way, all of the participants, whether in-house or virtual, will be able to hear your question. If you have a technical question about polling, please send an email to tclagholtz@provider-resources.com. If you have a technical question regarding the conference or the webcast, we ask that you send an email to CTO tech support at cms.hhs.gov. We also really value your opinion and your input, and we have a post-conference participant experience survey. We ask that you complete it either by following the link on the screen or utilizing the QR code. To use the QR code, if you have a smartphone, you're going to open your camera, line up the QR code, and then tap the pop-up window. If you are using the QR code with an Android, you're going to go ahead and go to your Play Store, search for a QR code reader, and then tap to install the app, and then go ahead and open that reader, and then line up the QR code with camera, and tap OK.
Okay, new this year, we have a CMS photo backdrop that is out in the hallway outside the auditorium doors. You may have seen it. So if you would like to have your picture taken in front of the backdrop, please take your phone out there and see one of our staff members, and they will be very willing to help you out with that. Couple other announcements that I have. If you have luggage today, you can store that in the back of the room, but please know that CMS is not responsible for it. Also, videos for the spring event from yesterday are not available for on-demand viewing until we receive management approval. And once we receive that management approval, a communication will be sent out to all of those who were registered for yesterday's event to let you know that those are ready and available. So we are glad to have all of you here with us today. Our agenda is packed with subject matter experts who are excited to share their knowledge and their expertise with all of us. So let's go ahead and get things started. Kicking things off for us today by providing an understanding of the changes to 2019 audits and universes from the Division of Audit Operations, Marie Gutierrez and Doreen Galliano.
Good morning, everybody. My name is Marie Gutierrez from the Division of Audit Operations, and I'm happy to kick off the first presentation today and talk to you about the new approach to 2019 audits and universes. I will go over the overall program package, then hand it over to Doreen Galliano, and she'll discuss the specific changes we made to each program area. The December 6, 2017 HPMS memo announced the 2018 program audit updates and our intent to redesign our information collection tools to maximize efficiency and reduce burden on the industry. We committed to redesign our audit record layouts, impact analyses, and other data collection templates and submit them to the Office of Management and Budget for Paperwork Reduction Act approval in the second quarter of 2018. So here we are, and I'm glad to say that we delivered on that commitment. There are definite similarities between how things are now and where we're headed in 2019, but as a direct result of the changes we've made, the meaning of and the way we use the term protocols going forward is changing. Prior to 2019, our overall audit package included publicly posted protocols, which were really by name and comprehensively the program area-specific audit process and data request documents. Some of these protocols were also accompanied by questionnaires, and we also had OMB-approved impact analysis and pre-audit issue summary templates. These protocols contained some information about how we conducted audits, while we still maintained internal methods of evaluation that included details of how we sampled and how we assessed compliance. Starting in 2019, in the spirit of transparency and as a way to streamline the Paperwork Reduction Act process, we separated our data requests from our audit process. While the data requests and our audit process still work hand in hand, what you will see in the 2019 and going forward are 1, data request documents that are subject to public comment through the Paperwork Reduction Act process, and 2, the reformatted audit process documents, which is what protocols will distinctly mean, that will be made public and include our methods of evaluation all the way from verifying universe integrity to sample selection and review. Data collection tools are posted currently on the CMS PRA website. The URL for that website is identified in the Federal Register notice. The change precipitated from that approach that will allow us to distinguish between what data we request and how we use that information during a program audit. Currently available and posted in the Federal Register for your comment are these data collection tools that we will use to request data throughout all phases of the audit. So that's the what data we will request, right? So please note that all of the data collection tools are there. Those that we kept as is, like the pre-audit issue summaries, those that we change, and I'll talk about that next, and those that are new, like the independent validation audit work plan template, which I'll talk about last. Then the documents that address how we use these data requests will be posted on the CMS website. These are the audit process documents. More specifically, the Program Audit Process Overview document, which contains audit principles that cut across multiple program areas, and the program area-specific protocols. The data collection tools are inclusive of all the information we will be requesting throughout all phases of the audit. These data collection points are the specific data requests, and as I previously mentioned, we've separated those from the audit process protocol information. Wherever possible, we simplified data collection by combining record layouts to better reflect plan operations. We adjusted the scope of the data we were collecting based on past audit experience and to ensure we're only collecting the volume of data necessary to conduct our analyses. We removed data points from our collection that created unnecessary burden for sponsoring organizations, and we clarified other data points in response to the questions you sent to our Part C and D audit mailbox, as well as questions and feedback we received from audited sponsors and lessons learned from our own auditors and other stakeholders. Sorry, I forgot to forward a slide. All right, we're caught up, or you're caught up. Within the revised data request documents, which are specific to individual program areas, you will find data requests organized by audit phase. For instance, in the audit engagement and universe submission phase, you will see our requests for universes or the applicable universe record layouts, which are descriptive tables that explain the data that is required in each universe submission, and the supplemental documentation that we collect up front to help us understand your operations and allow us to select better samples and better guide you in universe preparation. An example of supplemental documentation that we collect are the questionnaires. During the audit fieldwork phase, auditors may request supporting documentation specific to a failed sample case, like a copy of a decision letter. Auditors may also request root cause analyses, which help you identify the reason for the noncompliance, as this is essential for eventual correction, and impact analyses. Within the data request document, you will find detailed record layouts that describe each of the data fields we need to collect from you to better understand the scope of the noncompliance. This is one of the bigger changes in 2019. So if you've been audited before, you're probably familiar with the impact analysis templates in Excel. And if you're not familiar with them, that's okay too, because we've removed them. But what you will see in the data request document is an impact analysis request in a format that is consistent with the universe record layouts. By getting rid of the Excel templates, we were able to incorporate field descriptions for each of the data points we are collecting. And not only will this change make the impact analysis submissions more consistent amongst audited sponsoring organizations, but it will also make the submissions easier and more efficient. The new impact analysis record layouts, akin to the universe record layouts, have a defined review period, which often quantifies the scope of the noncompliance through the date the issue was identified on the audit. And it'll also include better instructions in the form of inclusion and exclusion language that sponsoring organizations capture the cases that were affected by the identified noncompliance and exclude any cases that were not related to the noncompliant issue. But as we moved away from that impact analysis template in Excel, we still needed the root cause analysis tab, and that was the other spreadsheet within that old or gonna be retired Excel template. So we created a separate root cause analysis template and took the opportunity to improve it by making it a fillable template. The new template is also applicable to all program areas, so you can use it for ODAG, CPE, CDAG, and the other program areas. It was designed in such a way that sponsoring organizations can hone in on the root cause of the overall issue. As you conduct the root cause analysis and complete the template, you're looking beyond the specific failed sample case. you're determining the reason for the greater or widespread issue of noncompliance, or this beyond the case level analysis could provide assurance that the noncompliance is not widespread, or the noncompliance could be limited to a specific segment within your organization. The root cause analysis will be requested separately from the impact analysis, and auditors will evaluate the root cause statement provided by the sponsoring organization to determine whether the request for a full impact analysis is warranted. Later this afternoon, Brenda Hudson will be presenting on the details of independent validation audits, but speaking of fillable templates, we created the Independent Validation Audit Work Plan template for use by sponsoring organizations with their independent validation auditor. The idea of the IVA Work Plan template was based on our audit, validation, and closeout document that is accessible on our website right now. And it is also based on feedback that we received as a result of our July 2017 listening session and the proposals we finalized in the April 2, 2018 call letter. Not only will this new template ensure consistency, it would also increase the likelihood of complete work plan submissions. Please note that the IVA Work Plan template lists other documents that need to be submitted with a completed work plan. Specifically, the validation auditor's resumes and the audit report template will need to be submitted with the completed work plan. Again, we encourage you to review any and all of these data collection tools that are currently posted in the Federal Register and provide us with your valuable comments. So now that we've discussed all of the data collection tools that are currently in the Federal Register, we'll turn our attention to the audit process documents. And this is the part that completes our overall program audit package. And although not subject to the Paper Reduction Act comment process, these documents will be posted on the CMS website for public use. More specifically, the Program Audit Process Overview document and the program area-specific protocols will be made available to provide more insight into our audit principles and approach for sampling and evaluation. The intention is to make it more useful for sponsors to conduct mock audits or for independent validation auditors to conduct validation audits, as these documents address how the data collection is used. The current Program Audit Process Overview document, available on our website, was designed to provide an executive summary of our audits by phase, as well as a more detailed description of steps within those phases. For 2019, we've decided to broaden its purpose. In our approach to our audit tools, in our new approach to our audit tools, we plan to update the existing Program Audit Process Overview document to include, in no particular order, our scoring approach, which remains unchanged, our descriptions of tracer case summaries, which will be applicable to both CPE and SNP QIPI, our methodology for quantifying noncompliance as collected within our impact analyses, our application of the pre-audit issue summaries, or application of mitigating factors for noncompliance that was self-disclosed to us prior to the date of engagement letter, as we classify our audit conditions, and other audit-related principles that cross-cut different program areas, such as integrity testing and invalid data submissions. The program area-specific protocols are being reformatted for ease of use and updated to provide more transparency in our method of evaluation and sampling approach. The intent behind our redesign efforts is to provide our stakeholders with an audit process document that easily links each data and documentation request to an audited element related to scoring and a compliance standard tied directly to a regulatory and sub-regulatory guidance. The program area-specific protocols will provide more detail on our approach to integrity testing, That is verifying that data and documentation requests are accurate and complete, and our approach to selecting targeted samples. So what can you expect to see in each of these program area-specific protocol? Well, first you'll see an element that is being tested. So for example, in the ODAG protocol, timeliness is one of the elements. Next, you'll see a sub-element, and that sub-element will provide a more detailed description or a breakdown of the element being tested. So in keeping with my example from the ODAG protocol, if the element is timeliness, then the sub-element may be timeliness of notification. And then you'll also see documentation requests, and this will identify the source of the data being evaluated, as well as any documentation that may be requested upon identification of non-compliant sample cases. So you can think of the documentation requests information as the crosswalk between the data request document and the protocol. And again, as an example from the ODAG one that we're building on, the corresponding universe used to measure the timeliness of notification is what would be one of the documentation requests that you'll see. Next is a compliance standard, and this will provide a description of the requirement being tested as quoted from the regulatory and sub-regulatory guidance. And you'll also see the criteria. And this will be the reg or manual reference to the cited compliance standard. And lastly, the protocols will specify and include our method of evaluation. The detail of our sampling and evaluation approach, better known as the method of evaluation, was previously kept internal to just CMS, to us. But however, in our redesign, we will be sharing in keeping with our efforts to remain, we will be sharing this information in keeping with our efforts to remain transparent. The method of evaluation that you'll see in the protocol will include a detailed description of our universe integrity testing information and a description of our sampling approach once the usability of all those universes have been verified. And if you've been audited before, you may recall that auditors conducted integrity testing specifically in the ODAG and CDAG program areas. But starting in 2019, universe integrity testing will be expanded to all program areas. Actually, in 2018, we will be piloting integrity testing in the FA program area, and we'll do that in less than 9 audits this year. The purpose is to determine the completeness and accuracy of the universe submission from which samples are selected and compliance is assessed. For starters, the auditors will check if all the contracts are included, all requested dates are represented, and all of the fields in the record layout are complete and, that they make sense. The universe integrity testing may necessitate universe resubmissions, which then feeds into the process for determining an invalid data submission condition. Overall, it's an opportunity to ensure on the front end that the data is good and usable for sampling. And then as far as sampling is concerned, our intent is to provide enough detail so that a sponsoring organization using our protocols to conduct a mock audit or an independent validation auditor hired by the sponsoring organization to assess correction from a program audit has the same insight into our targeted sampling approach as our auditors who initially conduct the program audits. That means you may see that we target call logs for for cases that appear to be misclassified grievances or coverage requests, or you'll find details about targeting grievances that appear related to quality of care and really to ensure enrollees were provided with the appropriate contact information for the QIO. So to recap, the overall program audit package consists of the data collection tools, which are currently posted in the Federal Register for your review and comment, and the audit process protocol documents, which will be posted on the CMS website. We hope you'll see that the new approach to the 29 audits is in keeping with our efforts to continuously improve, reduce burden, and increase transparency. Thank you for your attention, and at this time, I'd like to turn over the presentation to Doreen Galliano.
Good morning. I'm Doreen Galliano. Thank you, Marie, for the first half of our presentation. I am going to walk through the changes that we have made to each of the audit areas, but first I wanted to summarize some of the high-level changes that we have made and the considerations that we have taken into account for the reasons behind those changes. As Marie previously mentioned, in redesigning the data requests for the next audit cycle, we really focused on reducing burden to sponsors by only collecting the minimal information necessary to conduct one of our thorough audits. We took into account the frequently asked questions that come through our audit mailbox, and we relied on auditors' experience, sponsor experience, and the insight that we have gained from auditing sponsoring organizations in order to propose a more streamlined and meaningful data collection instrument. Specifically, we consolidated record layouts wherever we could, and we removed unnecessary data points that were no longer meaningful for sampling. Further, we clarified instructions for responding to universe requests, as well as field descriptions to accommodate concerns we have heard in response to current protocols. Along the lines of streamlining our requests, we also reconsidered the use of our questionnaires. We removed questionnaires that were no longer necessary or that were not being used as we had initially intended. And we added new questionnaires to consistently capture information that was being requested verbally in our current audit process. And we reformatted all the questionnaires as fillable forms to reduce burden and to further clarify the information for which we are seeking to collect. The program area specific changes are summarized in the crosswalk that is included in the PRA package on our CMS website. We will now discuss each program area in greater detail, and we will start by looking at special needs. You will first notice that we changed the name. Instead of referring to Special Needs Plans Model of Care, or SNP-MOC, we have renamed the program area to better reflect the scope of our review. The program area is now named Special Needs Plans, Care Coordination and Quality Improvement Program Effectiveness, or SNP-KIPP. We also redesigned our data collection to collect less data. Previously, we requested 13 months of data. Starting in 2019, the idea is to collect a list of information as of a specific moment in time, namely a listing of all enrollees and a listing of all models of care at that time of the audit engagement letter. From these revised universes, we intend to conduct more of our assessments as it relates to timing of health risk assessments at the universe level. Continue assessing care coordination via strategized sampling, and we hope to review an organization's quality improvement process using a tracer methodology similar to that which is used in our review of compliance program effectiveness. We also added a questionnaire to our data request that collects information that is useful to us in selecting samples that will be reviewed using the methodology that I just described. The questionnaire asks questions that helps us understand your organization's operations as they relate to special needs plans, and asks questions such as, has your organization experienced any seamless enrollments, PDP mergers, acquisitions, or plan consolidations? And if so, please describe the circumstance. In Part D, Coverage Determinations, Appeals, and Grievances, better known as CDAG, we reduced the number of universe submissions that we require for both program audits and timeliness monitoring project universes. In CDAG, we went from 16 universes in 2018 down to 8 for 2019. That I will outline for you in some upcoming slides. Although the reduction in universes strikes some as a major change, we want to assure you that the compliance standards remain consistent with our previous protocols. We are still reviewing the same sample cases, similar criteria within the same elements. You will also see on the upcoming slides that we have added one new universe in CDAG. And this is to evaluate processing and classification of requests. This new universe serves as a catch-all for any unprocessed cases or cases that are inactive or resulting in something other than an approval or a denial. It will include cases that the sponsor deems to be invalid, unprocessed, dismissed, withdrawn, or canceled. Additionally, we have removed the CDAG supplemental questionnaire. Instead of asking about your policies up front, we collect and assess any policy-related information as we collect the root cause analyses. We found that this is a better fit for outcomes-based testing approach. And finally, we increased the scope of some universe periods, such as grievances and overturn decisions based on past audit experiences. But we also reduced the scope of some universes, such as the call log universe. This will help reduce burden on sponsors. We also rephrased our requests from monthly to weeks to promote additional consistency in the amounts of data collected from like-sized organizations. Now I would like to walk you through a crosswalk of the 2018 to 2019 CDAG record layouts. The left side of this chart shows 2018 record layouts, and the right side of the chart shows the new and equivalent record layouts for 2019. In 2018, Table 1 is standard coverage determinations, and Table 4 is expedited coverage determinations. For 2019, collection of standard and expedited cases will be combined in Universe 1 or Record Layout Table 1, which is called Standard and Expedited Coverage Determinations. In 2018, Table 2 is Standard Coverage Determination Exception Requests, and Table 5 is Expedited Coverage Determination Exception Requests. In 2019, both Standard and Expedited Coverage Exception Requests will be combined as described in Record Layout Table 2, Standard and Expedited Coverage Determination Exception Requests. In 2018, Table 3 is Direct Member Reimbursement Request Coverage Determinations, and Table 7 is Direct Member Reimbursement Request Redeterminations. In 2019, all DMR requests, whether at the CD or redetermination level, will be included in Record Layout Table 3, which is called Payment Coverage Determinations and Redeterminations. In 2018, Table 6 is Standard Redeterminations, and Table 8 is Expedited Redeterminations. In 2019, Standard and Expedited cases are again combined in Record Layout Table 4, resulting in a combined universe of Standard and Expedited Redeterminations. In 2018, Table 11 is Standard IRE, ALJ, or MAC determinations, and Table 12 is Direct Member Reimbursement Request by other review entity, and Table 13 is Expedited IRE, ALJ, or MAC determinations. In 2019, these three record layouts have been combined into Record Layout Table 5, Part D, Effectuations of Overturned Decisions by IRE, ALJ, or MAC. In 2019, we have also combined Standard and Expedited grievances in Record Layout Table 6, which were previously collected separately in 2018 per Record Layout Tables 14 and 15. On this slide, you can see where we have introduced a new record layout, Table 7. to collect a universe of unprocessed cases. As I mentioned earlier, this universe serves as a catch-all for unprocessed cases or cases that are inactive or resulting in something other than an approval or a denial. It will include cases that the sponsor deems to be invalid, unprocessed, dismissed, withdrawn, or canceled. In 2019, Table 8 should look pretty familiar as it is equivalent to the Record Layout Table 16 for 2018, which what is currently called Part D call logs. And finally, you may have noticed that there are 2 existing record layouts in 2018 that are going away. In 2019, we will no longer collect universes for standard and expedited cases that were auto-forwarded to the IRE. We removed these record layouts as they are often duplicative of other cases that we are already looking at in earlier universe record layouts. Now moving on to ODAG, I will walk you through the changes made that should sound very familiar to the changes that we just discussed in CDAG. Once again, we consolidated collection of standard and expedited cases to reduce the number of universes for submission in our program audits and our timeliness monitoring project. We also kept the compliance standards relatively stable, except for where there were changes in policy. We removed the supplemental questionnaire also. So let's take a look at a crosswalk of the revised universe record layouts. By consolidating similar cases, we were able to reduce the number of ODAG universes collected for both program, audits, and timeliness monitoring project, from 7 down to 3, as shown on this slide. In 2018, Table 1 is standard pre-service organization determinations, and Table 2 is expedited pre-service organization determinations. In 2019, Table 1 will be standard and expedited pre-service organization determinations. In 2018, Table 5 is standard pre-service reconsiderations, and Table 6 is expedited pre-service reconsiderations. And in 2019, Table 2 will be standard and expedited pre-service reconsiderations. In 2018, Table 3 is requests for payment organization determinations, Table 4 is direct member reimbursements, and Table 7 is requests for payment reconsiderations, and Table 9 is IRE payment cases requiring effectuation. In 2019, Table 3 will be payment organization determinations and reconsiderations. In 2018, Table 8 is pre-service IRE cases requiring effectuation. Table 9 is IRE payment cases requiring effectuation, and Table 10 is all Part C ALJ MAC cases requiring effectuation. In 2019, Table 4 will be Part C effectuations of overturned decisions by the IRE, ALJ, or MAC. In 2018, Table 11 is Part C, oral and written grievances. Table 12 is Part C, oral and written expedited grievances. And in 2019, Table 5 will be standard and expedited grievances. In 2018, Table 13 is dismissals, and in 2019, Table 6 will be dismissals. In 2018, Table 14 is call logs Part C. In 2019, Table 7 will be Part C call logs. So to wrap up the changes we have made to ODAG and CDAG, and before we move on to discuss changes that we have made in compliance program effectiveness, I wanted to revisit one of my earlier points related to keeping the compliance standards the same. By keeping compliance standards relatively stable between 2018 and 2019 for CDAG and ODAG, again, except for changes to guidance or policy, we were also able to keep the program elements the same. Any changes to elements for CDAG and ODAG are by name only, as shown on the slides. Timeliness in 2018 is still called timeliness in 2019. Appropriateness of clinical decision-making and compliance with processing requirements in 2018 has been renamed to processing of coverage requests. And grievances and misclassifications of requests in 2018 has been renamed to classification of requests for 2019. For compliance program effectiveness, we will review the same 3 elements as we have done in previous years, which include prevention, detection, and correction controls and activities. We will use the same method of evaluation, which includes tracer summaries and employee samples, to review the following items: oversight activities of first-tier entities, employees who are responsible for oversight of your Medicare program, and your auditing and monitoring of internal operations. And the following things have changed. We removed the self-assessment questionnaire to reduce program audit burden, but don't worry, we now know that sponsoring organizations use this document to help in their operations as they prepare for CMS program audits. So this particular document is still available on our website for you to use. It is just no longer part of the data request that we will use for program audits. We combine the internal auditing and internal monitoring universes, or record layouts, and we streamlined data collection for oversights of FDRs. For instance, one of the more notable changes is the removal of one of the most burdensome data points related to how long an entity has contracted with the sponsoring organization being audited. We are collecting less data points for the ECT universe because there was a lot of burden associated with this. We also changed the names of the record layouts, but these changes really were minimal. Finally, the existing questionnaires were made into fillable forms, as Marie did describe earlier in our presentation. Last but not least is Formulary Administration, and we decided to end with this program area as it has experienced the least number of changes for 2019. Overall, we are collecting pretty much the same fields. We just consolidated record layouts for rejected claims, and we clarified a few field descriptions. We also amended our record layouts in FA to account for the transition from the HICN to the Medicare Beneficiary Identifier. To assist with sampling, we did add a supplemental questionnaire that asks sponsoring organizations about their operations, to include items such as if you utilize prior claims history for purposes of transition, for existing enrollees having a plan benefit package change, or if you have a specific prior authorization form, if you have employer group waiver plans, which submitted claim fields you use to determine if an enrollee is subject to long-term care requirements, if you or one of your delegated entities will be walking auditors through the various screens within the applicable platforms reviewed during the audit, and finally, if you utilize any methods other than claims history to ascertain new versus ongoing therapy for enrollees. This questionnaire will be due within 5 business days of receiving your audit engagement letter. And auditors will use this document to guide the conversations when they meet with the audited organization prior to universe submission. And finally, the last update I wanted to mention relative to SFA is more closely related to the protocol as opposed to our data requests, but it's important and it may be of interest to our audience today. Although there were minimal burden associated with the website review element in our actual program audits, we have suspended this element due to its overlap with other ongoing monitoring projects conducted within CMS. So this concludes our presentation on our overall audit approach to program audits and universe collections starting in 2019. We've walked you through what our PRA package will look like, as well as described for you some enhancements you can look forward to in our audit process documents. If you have specific questions about this presentation, please email them to our audit mailbox shown on the screen and in your slides, paying close attention to the underscores. And for questions, or if you are interested in providing comments on our actual data collection tools for 2019, you can follow the instructions in the 60 and 30-day Federal Register notice. Keep in mind that the comment process is different for each. To find the notice, you can search the Federal Register for package ID number CMS 10191. Again, that's CMS 10191. You should use the same number for finding the PRA package that is posted to our CMS website. And finally, just a reminder that the changes are subject to OMB approval under the PRA process, and as such, the changes are not yet approved by OMB, so you should not take any action until the time of OMB approval. Thank you very much.
At this time, we are out of time for questions for our in-house participants. Please feel free to save your questions and ask them during our open Q&A session this afternoon. And our webcast participants, please feel free to submit your questions during with the SurveyMonkey link. Thank you, Doreen and Marie, for the update on the 2019 audit and universes. It is now time for our first session evaluation. Please take out your phones if you will text your response or go to the poll EV link on your smartphone, tablet, or computer. If you would like to evaluate this session, and we encourage everyone to do so, and you are participating via your cell phone, go ahead and enter A in response to the question, "I would like to evaluate this session," and send your response. You will receive a text message with the following message: "Hello, please evaluate this session with this link." Select the link, and you will be taken to the Poll Everywhere site. Choose Start, and you will be presented with the evaluation questions one at a time. Select your answer and click Next to advance to each question, and then go ahead and submit your response by choosing Finish. If you are participating via the internet, when prompted by the moderator, choose Yes in response to the question, "I would like to evaluate this session," and you will be presented with the link to evaluate the session. The link appears quickly at the top of the screen in green, so click on that link. When the next screen appears, choose Start. You will be presented with the evaluation questions one at a time. Select your answer and click Next to advance to each question, and then submit responses by choosing Finish. Okay, our next session will provide an overview of how the Division of Compliance Enforcement analyzes program audit referrals to determine if enforcement actions are warranted. From the Division of Compliance Performance, I am pleased to introduce Ann Levenstam.
Good morning, everyone. I'm Ann Levenstam. I work in the Division Compliance Enforcement. I'm the technical advisor there. I want to apologize for my voice and potential cough today. Of course, of all the weeks that one could get a cold, this was the week that I got a cold. So I'm sure that most of you don't like the word enforcement or don't like the idea of receiving an enforcement action, but I hope that after hearing this presentation today, you'll recognize the importance of our work and understand a little bit more about the process of, that we take in order to make determinations on whether or not an enforcement action is warranted. The Division of Compliance Enforcement is the division, also known as DCE, is the division that is responsible for taking all enforcement actions against Medicare Advantage organizations, prescription drug sponsors, cost plans, and PACE organizations. As you can see, we are also in the same group as the audit divisions, and although that may be the case, we view ourselves as independent from the other divisions as well as other components within CMS, as it is our job to ensure that the violations that come to us meet the regulatory standard for an enforcement action. And we do take that job very seriously as we recognize the impact that it has on sponsors. Today I'm going to be mostly talking about, well, first I'm going to just give a very brief overview of enforcement actions, but mostly I'm going to be talking about the process that we work through to determine whether or not a CMP is issued in the program audit world. Specifically, I will be discussing how we get referrals, how we analyze the case, what data we look at, how we look at impact analysis. I will also be talking about our CMP calculation process and the changes and enhancements that we have made, and also the increased transparency that we have on this process. I will also be talking a little bit about the sanction process and how we analyze cases for that. And then I will also talk about other referrals that we receive that result in enforcement actions. And finally, if everyone is paying attention, we will have some polling questions at the end for you to answer, and then hopefully some time for questions and answers from the audience. Most of you probably are very familiar with the types of actions that we take. Although, just a quick refresher, and if anyone's new to this, there are 3 types of enforcement actions that we can impose against sponsors, and those are civil money penalties, also known as CMPs, intermediate sanctions, and terminations. And although we can use the same bases for any of these actions, the reasons why we impose them are very different, and they do go in order of severity. So, for example, the CMP is the least severe of the action, but it is also most commonly imposed. That is the action that we impose on sponsors who have past noncompliance that impacted beneficiaries. We impose intermediate sanctions when we have significant concerns that there are widespread issues within the organization, or if the organization is not able to correct those issues quickly. When we impose intermediate sanctions, we often suspend the sponsor's ability to market to or enroll beneficiaries, and that will last until the sponsor can demonstrate correction, which could be about a year-long process. The top 1, terminations, is obviously the least common that we impose, but it is the most severe enforcement action that we can take. And those would be on the most egregious violations that would occur, also potential financial insolvency issues, as well as if there's any statutory reason for us to terminate if a sponsor doesn't meet certain criteria. And the purpose of our enforcement actions is twofold. One, it's to ensure that sponsors meet the regulatory violations, and also to ensure that our beneficiaries are protected. So you are probably all wondering what we do in our enforcement world. We wonder if when we were sitting in a cubicle, flipping a coin, deciding who's going to get a CMP and who's going to get a sanction. And of course, I'm just kidding. But really, what do we do? What kind of information are we looking at? How do we get the referrals? How do we look at the data? How do we look at impact analysis that you send us to make those determinations? I'm going to talk about this step-by-step process of a life cycle for how we make determinations on whether or not a CMP is warranted. The first step is we receive the referral. So in the audit world, you receive an engagement letter, and then you go through an audit process, and then you probably are wondering what's going to happen next in the enforcement world. Well, the next steps is that we would receive DCE would receive a referral from our Division of Audit Operations based on certain criteria, and that includes the sponsor's audit score, whether or not the sponsor had any ICARs, and or whether or not, or how many beneficiaries are impacted for various violations. Once we receive the referral, we will outreach to the sponsor to notify the sponsor that we've received the referral. And that doesn't necessarily mean that you're going to get an action or a sponsor is going to get an action. We notify the sponsor that we've received the referral and that we're investigating it. And that will usually be around the time that the sponsor receives the draft audit report. And, but it could happen earlier in the process. So once we receive the referral, we gather all of the documentation that the audit team has collected, and that includes work papers, audit sample documentation, impact analysis data from the sponsor, as well as details from the audit report. And if we have questions about the audit results or if we're unclear of what happened on the audit, we're in regular contact with and conduct outreach with the audit team to discuss any of those questions that we have on the various conditions. If we have further questions, especially around impact analysis data that came from the sponsor, we will also conduct outreach to the sponsor. This year, if your organization is selected for audit, please expect to hear from us even more with our outreach attempts as we're continuing to try to improve our process for analysis on these cases. And that brings me to the discussion on what we look at when we're reviewing impact analysis data, because that is data that is provided from the sponsors, and that is often what we conduct a lot of outreach on. We do analyze the information in the impact analysis very carefully. If there's information that is missing because the sponsor did not complete certain columns or maybe wrote NA where it should have actually been data, we will conduct outreach to get that information if we need it. If we need additional columns completed because we need additional information from the sponsor, we will ask the sponsor to complete additional columns. Also, if there are any discrepancies in the IA, we will contact the sponsor. So for example, if a sponsor had a formulary condition and IA showed that the beneficiaries did not receive their medication within a certain period of time, and that number did not match up with dates that are in the IA, we're going to be conducting outreach to the sponsor to understand where the discrepancy is. So with that being said, we expect sponsors are, during the audit, spending time completing their IAs fully and also validating to ensure that their IAs are correct. However, we will be conducting outreach to clarify information, so sponsors will be given that opportunity. At some point, though, after significant numbers of outreach attempts and discussion with the sponsor on additional information that we need, if the sponsor cannot gather that, we will have to move on with the information that we have in making our determination. In addition to our excuse me. In addition to our detailed review of the impact analysis, we also conduct an IA validation, or we may conduct an IA validation for sponsors. And what that entails is that we would contact the sponsor and let them know which particular IAs we're going to be validating. We will be conducting a webinar and asking the sponsor to walk through exactly how the data was pulled from their system and is input into the impact analysis. Most of the time, these impact analysis validations are done on formulary conditions. However, this year and going forward, we're most likely going to be expanding that into other program areas. And also, I would like to just discuss one more thing about our outreach to sponsors, in that it is a separate investigation from what is going on in the audit, with the audit team. Sponsors may find that during the time where we're conducting outreach and asking questions, you are still working with the audit team in finalizing audit data. But our questions are really not to be necessarily meshed with the questions and the work that's going on the audit team, because our investigation and our analysis is slightly different from what is going on in audit. And we may need additional information that the auditors don't necessarily need. But therefore, we will make sure that sponsors are aware, when we're conducting this outreach, that this is specifically for an enforcement investigation and not necessarily, related to the audit. And then finally, we do also look at documentation from the sponsor. You're given an opportunity to respond to the draft audit report. And so if sponsors have concerns or disagree with findings in the audit report, they should make that known in the responses to the draft audit report, and we will look at that and take that into consideration. So once we have all of our documentation, our next step is to conduct our analysis. And we have certain criteria that we have to meet in order to make that determination of a CMP. So the first one is that we have to see that there was a violation of a clear requirement. And then the second step is that we have to see that that violation was substantial, meaning systemic. And in our world, when we look at whether or not something is substantial, we may look at how many beneficiaries were impacted. And that includes both the percentage of beneficiaries that were impacted and also the number of beneficiaries that were impacted. We also look at how many cases failed on audit. If there was a significant number of cases, that shows that the issue might be substantial. And then we also look at the root cause. Depending on what the root cause is from the sponsor can indicate whether or not an issue is substantial. So it's not just one of these that we look at, it's all of them holistically together that we look at when making substantial decisions. Our next step that we have to meet is that there has to be adverse impact or the substantial likelihood of adverse impact to enrollees. And the most common examples of that on audit are denial of medications or services, or denial or that the access to the appeal process was impeded, either because the sponsor did not make timely decisions, or maybe there was a misclassification issue. And then the last one is we often see is enrollees being impacted financially. The first two are fairly easy to see. Often IAs show when a beneficiary has been denied a medication, or if a coverage determination or organization determination was late. The last one can be a little more tricky because it's related to financial impact. And this one often shows up in the ODAG portion of the audit. And when there is inappropriately denied claims, such as for plan-directed care, emergency care, or other covered services. We'd like you all to know that if there is a substantial likelihood that enrollees could have been billed by a non-contract provider, we will impose a CMP for any enrollee that had the potential to be billed. And this is important for all sponsors to be aware of, because what we have seen sometimes is that there has been a denial of, say, plan-directed care, and then the sponsor writes $0 liability for the member on their EOB. But in all cases where there's a non-contract provider, that non-contract provider can bill the beneficiary. And if it's an inappropriate denial and there's that potential for that beneficiary getting a bill, or they were billed, we will consider that adverse effect. And it does not have to be whether or not the beneficiary actually paid the bill. Finally, the last thing that we look at is just sort of generally other considerations. And the other considerations really feed into the first three prongs that we have to meet. But some things that we also look at when determining whether a CMP issued is whether or not the issue was discovered by the sponsor on their own, whether or not the sponsor notified the account manager of the issue, whether or not the sponsor quickly corrected the deficiencies, quickly corrected the issues for the beneficiaries. We can still impose a CMP even if the issue has been fixed, because CMPs are for past noncompliance. However, we will, if we see that a sponsor is proactive in identifying the issue quickly and that they remediated beneficiaries quickly, we will take that into consideration when determining whether or not a CMP should be imposed. And if we see that maybe the organization didn't discover the issue, or that even if the organization discovered the issue, they didn't take the steps to remediate the beneficiaries, and it had to be told on audit that they had to remediate beneficiaries, that will raise the chances that a CMP could be imposed. So we've hit our final determination. The three prongs have to be met. We have to have the violation, the regulatory failure, we have to have a substantial violation, and we have to have the adverse effect or substantial likelihood of adverse effect on the enrollees. And if those three prongs are met, we will most likely move forward with a CMP for that particular condition. That may be one condition in the audit. That may be many conditions in the audit. The sponsor may have received an amazing audit score or not a great audit score. And each condition is evaluated through these prongs to determine whether or not a CMP would be met. Sometimes, though, you may see that we combine conditions or combine information, and that is because the root cause or the violation was very similar. Most often, that might occur in transition type conditions where the root cause for a transition failure was the same. So once we have decided that a CMP is warranted for a particular condition, our next step is to figure out how we calculate that CMP for that particular condition. And if we have impact analysis data, we will use that data to calculate the CMP based on the number of the enrollees that were impacted. Each beneficiary is only counted once for one particular IA. However, a beneficiary may be counted multiple times if they've been impacted by different violations. So for example, if a beneficiary was impacted by a financial condition and then also impacted maybe for a misclassification condition, that beneficiary will be counted once for the financial, the formulary violation and then once for the misclassification violation. Our standard penalty amount is tied to each beneficiary impacted, and for CMPs in the program audit worlds, those result in a $200 standard penalty per our CMP methodology. And then aggravating factors can be added to the standard penalty amount for each enrollee that's impacted by an aggravating factor. Those include, the examples of those include the beneficiary was delayed beyond 24 hours for a medication that was needed for acute care, or that the sponsor has had a history of prior offense for that particular violation, and that could be from another CMP, that could be from another audit, or even a compliance notice. Another aggravating factor is for expedited cases in like the CDAG and ODAG world. If there is expedited cases and they have been delayed, an aggravating factor will be added to those. Another aggravating factor for the financial conditions is if a beneficiary has been charged in excess of $100. So here's an example of a calculation worksheet that we prepare when determining our amount. As I'll be discussing on the next several slides, we are now sharing these calculation worksheets with sponsors. You can see here, this is not a real case scenario, I just made up these numbers. But here an example is for this violation, 533 enrollees were impacted. The standard penalty amount, as I said, is $200. Therefore, the standard penalty amount for the 533 enrollees is $106,600. 46 of those enrollees had a delay of a medication that is used to treat acute conditions, and it was beyond 24 hours. So those 46 enrollees received, out of the 533, received an additional $100 tacked on to their CMP amount. And so the aggravating factor is for this particular condition is $4,600, for a total amount for this particular condition, $111,200. So last year, we published our first CMP methodology, and there were a couple of significant changes with how we calculated CMP starting in 2017. The first one is that we created more enrollment bands for our CMP cap amounts. We create enrollment bands because in order to have CMP amounts that do not become too unreasonable, we establish caps for various enrollment buckets of enrollment for sponsors in our CMP methodology so that a CMP for each violation doesn't exceed a certain amount. And this was really done, we added the more bands so that smaller organizations are not put into financial hardship due to CMP amounts. The second major change that we instituted was removal of the mitigating factor. Prior to the issuance of our CMP methodology, we would discount certain beneficiaries if we found that their adverse impact was substantially mitigated. Now we remove those beneficiaries from the calculation completely. So for example, if a beneficiary was denied at the point of sale for a medication but then subsequently received that medication that same day, we would consider that beneficiary substantially mitigated and remove that beneficiary. So given that, and there are other reasons why we might remove beneficiaries as well, but given this change, a sponsor may see that the number of enrollees impacted for a particular violation in their CMP amount is different from what is in the audit report. Another major change that we have is this year is now we're sharing our calculation worksheet, which I showed you on the previous slide. And we really do that so that everybody is aware of how we're calculating the CMP, how many beneficiaries were impacted, and the aggravating factors that were tacked on. So once our CMP is calculated and been developed, we have to go through several clearances. We have to ensure that we receive clearance from our senior leadership as well as the Office of General Counsel, who also gets in contact with DOJ and OIG. So there's a lot of clearance processes that we have to go through. But once we receive approval from all those clearances, we will contact the sponsor prior to issuing that CMP and discuss the action with them. Then we will email the notice to the CEO or the highest senior leader in the organization. And at that time is when we share the calculation worksheet that I showed you. If there are any questions from the sponsors, we are very open to having discussions, and we really encourage sponsors to contact us if they have any questions. And of course, all of our actions do have an appeal process included. Appeals are due 60 days after the date of the issuance of the CMP. But if the sponsor chooses not to CMP, they may pay the CMP at any time up to day 61, and they can choose to pay it by check, wire transfer, or deduction of monthly payment. And we, of course, provide details on how to pay those amounts if necessary. So next I'd like to move on to sanctions and discuss a little bit about that process, because it does differ from CMPs, and it does, I'm sure you all wonder, like, what would drive us from moving a sponsor from a CMP analysis to a sanction analysis. And several things that show up on audit can cause us to start heading down that analysis path. So the first thing is the number of conditions. If there are just a lot of conditions on an audit, that can be a warning sign for us that this may be a sanction. Also, the type of condition may be a warning sign to us. Some conditions may have had some really significant beneficiary impact, or in other cases, maybe a condition is not that commonly seen in other audits, and so that can be a warning sign to us that sponsors are not really clear on what the Medicare requirements are. Another one would be major breakdowns in certain program areas, and this could be all the program areas, or it could just be one or two program areas. We've had situations where sponsors have been placed under sanction and have done wonderful in formulary, but they had major breakdowns in CDAG or ODAG. We also look at compliance program. Although we don't CMP for compliance program fails, we definitely look at compliance program to determine whether or not a sponsor should be analyzed for a sanction. And if we see some very concerning violations, such as senior leadership not being engaged, the sponsor not conducting proper monitoring or responding to significant issues of noncompliance, that will raise our antenna for a potential sanction. And these signs don't always just come up in compliance program. We talk to the team leads, and we ask the team leads about how the culture was and how well they interacted with the subject matter experts from the sponsors, and whether or not they felt the subject matter experts were well knowledgeable in the material, and whether or not the auditors had confidence that the issues could be quickly corrected. And it doesn't necessarily mean that that particular issue could be corrected quickly. We also ask auditors if they felt like future issues could come up, and if those, that would show us that sponsors are not doing the proactive monitoring and, identification of issues that need to be remediated. And I know I've said this many times in other talks, and we've said this in other speeches, is that we don't expect sponsors to be perfect, but we cannot stress enough the importance of monitoring, identifying issues quickly, remediating beneficiaries quickly, and putting things in place to ensure future issues don't occur. We also look at the number of beneficiaries impacted, whether it was a large number of beneficiaries impacted over certain conditions. And then, of course, we also look at IDS conditions, if there's a large number of IDS conditions which show that the sponsor was not able to produce the data for the auditors to test. And then, of course, like I said, concerns about program knowledge, which we get through various discussions with the team leads. So once we have all of this information, we continue to investigate this organization. We will interview the account managers. We ask the account managers how the organization's rapport is with them and whether or not the organization is transparent with account managers. We also ask if the account manager has had seen significant concerns over the past year or so. And we look at compliance notices, a large number of compliance notices, also the types of compliance notices, whether it's warning letters, ad hoc caps, if it's the compliance notices show any of the same issues that were identified in audit, which would show to us that the sponsor continues to have the same issues over and over again. And we also look at complaints. If we see a high number of complaints or a high complaint rate, that can indicate to us that Medicare beneficiaries aren't receiving medications or services. And then finally, we discuss with all other components within CMS about the organization and see if they have any concerns. Another important point that I want sponsors to be aware of is that many times sponsors can find themselves in sanctioned territory when major issues occur that they weren't prepared for. For example, maybe like a spike in enrollment or a change in the process that would cause an increase in ODAG or CDAG cases. And this can often throw sponsors off guard, but it shows to us that maybe the sponsor wasn't necessarily proactive in preparing for the future needs of their organization, which is a major concern of ours. And so once we compile all of the information, we can generally get a good sense of how widespread and systemic these issues are and whether or not the organization is going to have trouble quickly correcting those issues and therefore putting beneficiaries at risk while they're continuing to operate. And if we feel like that's met and a sanction is necessary, we will move down that path. Now I'm going to talk about some other referrals we receive, not just, I've spoke mostly about the program audits, but we do get referrals for other types of actions. And here are the most common types of referrals, although we can always receive ad hoc referrals if there has been some major issue and, they can come to us. But the first most common type of referral that we get is our ANOC EOC referrals, annual notice of change in evidence of coverage. CMS requires that sponsors submit their annual notice of change in evidence of coverage at a certain time each year. And we receive referrals at the beginning of the year from our sister division in CM that for any late or inaccurate outliers. And we will analyze those cases. We look at the percentage of enrollees that were impacted. We look at how late the documents were. And we also, if in the case of an inaccuracy, we look at the type of inaccuracy and where it was located in the document. And so, after we analyze these cases, they may result in a CMP. The next one is the IRE auto forwards. CMS requires that sponsors send, also known as auto forward, cases to the independent review entity if they're late. And a high number of cases going to the auto forward indicates to us that sponsors are not making their decisions on time. And DCE now receives quarterly referrals from the Medicare Enrollment and Appeals Group on IRE auto forward outliers. And these may result in a CMP. In both cases, with ANOC EOC referrals and with the IRE auto forward referrals, we will conduct outreach to the sponsor and notify them they've been referred and verify information prior to issuing any kind of CMP. The other one that we have been recently getting is 1/3 financial audits. And last year we started to get these referrals, and they were started with for audits that were conducted on 2015 financial data. We created referral criteria with the Office of Financial Management for the types of cases that would be sent to our division, and these relate to incorrect copays, coinsurance, late enrollment penalty, and troop accumulations. Again, our division is conducting outreach with sponsors that have been referred to better understand the issues that occurred and to understand the adverse impact as a result of these failures. And as I mentioned before, with the financial impact in the program audit world, if we find that there has a potential that members could have been billed by a non-contract provider or even a contract provider, because we have noticed that there has been situations where contractor providers had inappropriately billed beneficiaries, we will consider that to be substantial likelihood of adverse effect. Additionally, we have also seen if beneficiaries had to pay out of pocket at the point of sale for a medication, to receive a medication or service, we will also consider that to be adverse impact. We have almost completed our review of the 2015 one-third financial audits, and we expect to start receiving referrals for the 2016 audits as OFM is now conducting those. Oops, sorry, back. I'm not done yet. Finally, we have PACE referrals that we're receiving, and we're going to start receiving more of these referrals because the PACE audit process has now become more outcome focused. And we have also created a referral process or criteria based on the certain types of violations that are found during the PACE audits. And the violations that show that participants did not receive medically necessary items or services may result in enforcement actions. And so PACE organizations should be aware that CMPs and or sanctions may increase this year because we're receiving more referrals. However, again, as I stated before, related to our outreach, we always conduct outreach with a sponsor when they have been referred, and that doesn't necessarily mean that the sponsor or PACE organization will receive an action. It's just our investigation of the action. Okay, so now I'm going to go on to our polling questions. Just a caveat, these are general scenarios. Oh, everybody's got their answer already, it looks like. These are general scenarios. Each situation is dependent on other facts of the case. And the neat thing about our work is that every situation is different, and it actually makes our work really exciting because we never have a dull, same old case. So I'm just putting that caveat out there. So the question is, DC receives a referral where the sponsor has misclassified coverage determinations as grievances. There are 3 cases that failed on audit, and the sponsor submits an IA showing that the number of enrollees either never received a coverage determination, they never had a coverage determination started, or they never received their requested medications. Sponsor's root cause is they do not accept oral coverage determinations from enrollees. Does DCE, A, consider this for a CMP, B, consider this for a sanction, or C, decide not to pursue an enforcement action? And it looks like that most people have answered the correct one, which is consider this for a CMP, noting that there are 3 cases that failed and also a potentially large number of enrollees that were impacted. And the root cause is that the sponsor has a policy of not accepting oral coverage determinations from enrollees. That shows us that this issue is systemic and substantial. And there's also adverse impact here because the enrollee was either denied a coverage determination or didn't get their medication. The next question is, DCE receives a referral where the plan has denied claims from non-contractor providers when the beneficiary was referred by the contractor provider. Sponsor submits an IA showing that a number of enrollees were billed by the non-contract provider or cannot confirm whether the enrollees received bills from the non-contractor provider. Does DCE A, consider this for a CMP, B, consider this for a sanction, and C, decide not to pursue any enforcement action? People. So it looks like most people are showing A, which is correct, consider this for a CMP. And again, this is one where you have a clear violation. This is plan-directed care. Contract providers, when they refer a beneficiary to a non-contract provider, is plan-directed care. And if we see an IA showing a number of enrollees either were not billed or we cannot confirm whether or not they were billed, we will consider that to be adverse effect or substantial likelihood of adverse effect. Okay, DCE receives a referral where the plan had a high number of conditions in the area of CDAG, including IDS conditions where the plan couldn't produce universes for the audit team. There were also several concerning conditions in compliance program portion of the audit. Does DCE, A, consider this for a CMP, B, consider this for a sanction, or C, decide not to pursue any enforcement action? So it's leveling out, and the correct answer is B, consider this for a sanction. We have, concerns here because there's, looks like there might be a major breakdown in the CDAG area. There's also IDS conditions where the sponsor's not, we can't even test whether or not the sponsor's following our requirements. And then we also have concerning compliance programs. So those things show us that there might be a sanction. Now, considering for a sanction doesn't mean that the sponsor is actually going to get a sanction. Like I said, we do a lot of investigation before we make that determination. DCE receives a referral where the sponsor has failed to cover medications because they were imposing quantity limits that were more restrictive than what was approved on its formulary. Most enrollees in the impact analysis received their medication within the same day. In addition, this issue had been identified by the sponsor quickly, and they had worked to fix the issue as soon as it was discovered. Also, beneficiaries who did not receive their medications were remediated quickly. Does DCE, A, consider this for a CMP, B, consider this for a sanction, or C, decide not to pursue any enforcement action? So the correct answer is C, decide not to pursue any enforcement action. And of course, I am going to again caveat that this is just a general scenario. So like every situation, we have to look at the facts and circumstances. But in general, because the sponsor is showing that they're quickly correcting, they're identifying issues, they're proactive in remediating beneficiaries, we're going to take that into consideration, and we would likely not impose a CMP. All right, that is all for my presentation, and I'm not sure, do we have time for questions?
We sure do.
Okay.
Okay, if anybody in our audience would like to present a question, please step to the microphone in the center aisle. Let us know who you are and where you're from. Oops.
Good morning. Derek Fry from the Birchfield Group. Can you give us some examples of what you consider to be a high number of conditions and what investigation might look like before you decided a sanction is needed?
Well, a high number of conditions, there really isn't a specific number, but what we do is we will look at other cases where we've sanctioned organizations and we compare them. And high number of conditions is just one factor. If an organization had a high number of conditions and they were, we've seen situations where there's a high number of conditions and they're really not egregious violations, or it's kind of like a dual thing. It's like the type of violation and also a high number of conditions. We wouldn't just say, oh, this organization had a high number of conditions, the same number of conditions as this organization that was sanctioned. We've seen situations where there's actually a low number of conditions because maybe the organization had a lot of IDS conditions, which then ended up that we couldn't test anything. So there really wasn't a lot of conditions, but that's also a concern for us. So it's really more looking at all of the data holistically, and that's really important for our work. Taking all of the data, looking at the number of conditions, looking at the types of conditions, the number of beneficiaries impacted, looking at the organization as a whole, getting in contact with people and finding out what the history is like for this organization, and then making our decision. So that's the best answer I could give you.
Thank you.
Okay, any other questions from our in-house audience? All right, then we will move to some of the questions we received from our virtual audience. And the first one is, I am curious about the enforcement of Medicare Advantage plans under the 60-day rule and how that is applied to providers.
Okay, yeah, this was one of the ones that received earlier, and this does not really apply to our work.
Okay, the next question that we received. Long-standing SNP audits have demonstrated sponsor deficiencies that impact very vulnerable beneficiaries, yet there has not been any related enforcement actions so far. Please advise when CMS will include SNP results in enforcement actions.
Okay, thank you. We are looking at that this year. We're going to be taking a look at more of the SNP mock conditions and seeing if potential actions could be taken. I do want to make note that, if any other condition has impacted a SNP beneficiary, we will take an action, and we have been taking actions on MMPs, which, also relate to our dual and vulnerable beneficiaries, and we will be, now that there's the audit, SARAG and other audit program areas related to MMPs, we will be looking at those and taking actions against MMPs for them.
Okay, our next question. How does CMS determine which beneficiaries to mitigate and which beneficiaries to include an aggravating factor for?
Okay, so it depends on the circumstances. I gave an example of where the mitigating, and we, like I said, we removed the mitigating factor, but when we look at mitigating now, we're actually removing the beneficiary of the sponsor getting the medication to that beneficiary on the same day. Or another example would be that, they missed the misclassification of coverage determinations. The sponsor started a coverage determination, misclassified initially, but then started a coverage determination really quickly, or that beneficiary got the medication, within one day, which they would have gotten anyway, if the coverage determination had been started. So we look at all of that when determining which beneficiaries, are not impacted. And then, had been the adverse impact was substantially mitigated. As for aggravating factors, we have our standard aggravating factors listed out in our CMP methodology, and those are the ones that we use in order to determine which ones are aggravating.
Okay, do we have any additional questions from our in-house audience? All right, so if not, I would like to thank Ann for providing an overview of the analysis of program audits. All right, if you would like to evaluate this session, go ahead, take out your cell phones and enter A in response to the question, I would like to evaluate this question, or on your computer, iPad, tablet, or smartphone. Go ahead and click that link and follow it. Please join me in welcoming our keynote speaker today, the Principal Deputy Administrator and Director for the Center for Medicare. Please welcome Dimitrios Kozoukis.
Thank you. You're welcome. Hi, everyone. Good to see you all today. It's nice to join you and delighted to have you here today at the Audit and Enforcement Conference, particularly at this critical time for the Medicare Advantage and Part D programs. We've been on a bit of a journey, and I think started within the last year or so to really emphasize the program's potential and to try to unleash the potential of Medicare Advantage and Part D. It's a pleasure to talk about that some more with you today. In the context of how CMS oversees plan compliance with our rules. Our goal for today's conference is for each of you to understand where CMS is going and why when it comes to enforcement, and to give you a bit of insight into our overall vision for the programs. These conferences are critical to our efforts to ensure that people better understand our programs, our direction, and to provide you with an opportunity to ask us questions. I hope that they help you better understand not only where we're coming from, but how it fits into a broader picture. I'm going to spend a little bit of time recapping some of that for you today. Medicare Advantage and Part D play a critical role in the agency's overall effort to transform our healthcare system. As the Secretary and the Administrator have said, this is an important evolution of changing the healthcare system from one that pays for procedures and sickness to one that better pays for value. The question always arises then, what does value mean? It's hard to disagree with the notion that we ought to pay for value. It's a word that can mean a lot of different things to different people. I think that for our leadership and for this administration, we're saying that value means that patients are in the driver's seat. And this concept is one that naturally lends itself to Medicare Advantage and Part D because in those programs, plans compete for patients and consumers, ultimately for their enrollment as well as their loyalty year to year. And so it's important and natural that in the work that plans do, that they put patients in the driver's seat, because inevitably they are. They get to choose every year whether to stay or not. And so I think this is a goal that those of you who are gathered here in Baltimore and on the webcast understand quite naturally. As a result, Medicare Advantage and Part D are going to be at the forefront of this transformation or this evolution that I mentioned. However, there's still work to be done. And in order to continue making that progress, we have to move forward in several areas that many of you heard the administrator talk about in her keynote yesterday, including giving consumers greater control over their information through interoperable and accessible health IT, such as the Blue Button. This makes the patients more able to move between providers and plans and the like. Also, encouraging transparency from payers, plans, and providers, and removing government burdens that impede the transformation I discussed. I'll touch a little bit more on the last two, transparency and burden reduction today. When we talk about transparency, we must emphasize that transparency includes accuracy and accountability. It's no secret that there are widespread problems with the accuracy and completeness of the information in plans' provider directories, including those in Medicare Advantage. For beneficiaries to make informed enrollment decisions, the accuracy of provider directories must improve. This is a challenge that I know is large and significant and very complex, but it's vital that we make progress on this front. Yesterday, many of you heard from our Office of Communications with reference to CMS's efforts to revamp Plan Finder and our Medicare and You handbook. You also heard the administrator talk about the importance of improving beneficiary communications and empowering beneficiaries to make choices. All this can only be done with improved educational resources and materials that we put together. As we ramp up these efforts on our end, the plan community has an important role to play as well. Plans have a duty to ensure that enrollees are making choices based on valid, reliable, up-to-date information, and that includes plan provider directories. With the increased focus and attention to Medicare Advantage and the accuracy of information and about options as well as information that's relevant to beneficiaries making decisions on both our parts, we think we can work towards that patient-driven healthcare vision much more effectively. We know that patients or beneficiaries rely a great deal on knowing whether their provider is in the network when they're choosing a plan. And so for our vision of a patient-driven healthcare system to succeed, it's important that they know whether their provider is in network or not when they're making that plan choice. Understanding that there's always potential for changes, of course, as well. It will come as no surprise, however, to anyone in this room that provider directories continue to show a number of errors. So we continue to stress the importance of these directories and and wanted to give you a little bit of a sense of how that fits into the overall vision, why it's important for us. And while CMS could mandate a solution, you understand your business better than we do. You know what's worked and what hasn't. We expect plans to work with providers to identify meaningful solutions to resolve this problem. And with that in mind, we want to hear what next steps you have taken to improve the accuracy of provider directories. We also want to hear what barriers exist that prevent you from achieving the desired results. What does a true solution look like? And how does CMS help improve the overall, how can CMS contribute to this challenge? In terms of regulatory barriers to innovation, I'm pleased to also highlight a number of many important changes that reduce administrative burden and spur creativity and innovation in plan design for MA and Part D through the call letter, rate announcement, and final regulation released last month. It's a mouthful and the culmination of a lot of work. As you heard yesterday from the administrator, the policy changes for 2019 include significant new flexibility for plans to offer additional benefits that help enrollees live healthier, more independent lives. Under new flexibility for 2019, plans can offer benefits that compensate for physical impairments, diminish the impact of injuries or health conditions, or reduce avoidable emergency room utilization. In addition, starting in 2019, Supplemental benefits can be tailored to the needs of beneficiaries who meet specific medical criteria. With this new flexibility, plans will be able to improve care and outcomes for beneficiaries with particular health conditions. These changes open up significant new possibilities. We're excited about them and imagine that you are as well. When you submit your bids on that first Monday in June, we encourage you to think boldly and creatively about how you can harness the power of these changes to really improve care and expand the types of benefits you are providing to enrollees. We want to work with you to ensure that these changes are meaningful and transformative. We encourage you to err on the side of including these benefits in your bids. As in the past, we will review your submissions and discuss without penalty or prejudice areas in need of modification or clarification. 2019 is just the beginning, though. We're also looking forward to 2020 and already starting the work that is necessary to make that a success as well. In 2020, plans and providers will have even more flexibility in how to deliver care. With the implementation of the Bipartisan Budget Act, MA plans will be able to provide telehealth services as a basic benefit in Medicare Advantage. We also streamlined the review and approval process for materials that communicate health and drug plan information to beneficiaries, aligning it with what a reasonable person would consider when hearing the term marketing. This, in turn, will reduce unnecessary burden when it comes to what is submitted for CMS review. We also added the concept of communications, so stakeholders receive clear and concise guidance regarding our expectations on how non-marketing materials are produced and handled. In preparation for the 2019 marketing season, we recently provided some highlights of proposed changes to the marketing guidelines, now called the Medicare Communications and Marketing Guidelines, and sought your feedback. We specifically solicited comments on provider-based activities and whether the flexibility offered is broad enough to support and encourage new delivery channels. We also sought comments on flexibilities that enhance plans' ability to market competitively and foster fair comparisons, while making sure beneficiaries have clear and reliable information. We received over 300 comments, many of which were very positive and constructive. We expect that the changes made this year will lead to greater competition and greater value for beneficiaries. And where we don't make changes this year, we expect to have opportunities to continue encouraging competition and hope the feedback solicitation was the start of a longer internal and external process for dialogue. We received comments regarding the ability of providers to discuss plans with enrollees to ensure the plan meets beneficiary health care needs. With these changes, our aim coming up this year is to allow more in-depth discussions between providers and enrollees, as well as the sharing of materials in ways that better meet enrollees' health care needs, and so hence our exploration of those topics in the comment solicitation. We're also looking to find out how we can more clearly define the difference between plan communication and plan marketing, which would greatly increase flexibilities in how you communicate to beneficiaries. We're also looking to provide more concise information on which documents are on required documents, so you will more easily know whether these documents are marketing or communications and how or whether they will need to be submitted. Our ultimate goal is to ensure that materials that will require submission are those that truly benefit from that process. The best part is that we feel confident that the changes we're making, if adopted, will allow us to maintain the needed beneficiary protections that have always driven Medicare Advantage and Part D marketing policies. And while we're on the topic of reducing burden, the regulation we issued also eliminated the requirement that Part C and Part D prescribers and providers enroll in Medicare, traditional Medicare, that is. Instead, we adopted a more efficient approach in which we will compile a list of prescribers and providers that are revoked or otherwise precluded from billing Medicare Advantage or Part D. We also updated stop-loss protection requirements for physician incentive plans to better account for medical costs and utilization changes that have occurred since the final rule was published many years ago. We authorized more flexible actuarial equivalent arrangements to protect against substantial financial loss and allowed non-risk patient equivalents, such as Medicare fee-for-service patients, to be included when determining the deductible. We clarified the substantial financial risk test and how it applies to intermediaries who negotiate rates on behalf of physician groups. All of this should allow more flexibility in negotiating and designing value-based arrangements between plans and providers to further the transformation I mentioned at the beginning of the discussion today with regards to patient-driven health care. We also finalized policies responding to the President's call to end the scourge of the opioid epidemic. The policies provide Medicare with additional tools to combat opioid overprescribing and abuse, and to protect families and communities across the nation. Several important policies we have put in place to fight this epidemic include final rules for the lock-in programs for at-risk beneficiaries that limit access to opioids to one prescriber or one pharmacy. For beneficiaries we consider at high risk, we expect all sponsors to implement a real-time opioid care coordination safety edit based on a cumulative dosage threshold at the time of dispensing as a proactive step to engage both patients and prescribers about overdose risk and prevention. We're also expanding the already successful overutilization monitoring system, and we're setting expectations for safety edits at the pharmacy counter to limit initial opioid prescription fills for the treatment of acute pain to no more than a 7-day supply. Now, with these changes in direction in mind, we return to the particular focus of today's conference, audit and enforcement. As many of you know, 2018 concludes the second cycle of program audits. Already today, you've heard about our updated data request documents that are posted for public comment through the Paperwork Reduction Act process. These improved audit tools for use in the next audit cycle are the direct result of feedback we've received. We heard suggestions for clarification around the classification of Part C and D grievances and coverage requests, and are pleased that we'll be presenting to you some examples today to promote compliance with our program requirements. We have also again released our annual Part C and D program audit and enforcement report highlighting audit results and trends, as well as program areas where organizations continue to struggle with meeting CMS expectations. We continue to look for ways to educate the plan community, to clarify our guidance when necessary, and to improve overall compliance. We continue to refine our audit processes to increase transparency, and we are committed to engaging with external stakeholders to ensure we are evaluating compliance with fairness and consistency. We are striving to reduce burden through regular updates to our process, our tools, and our guidance, including the recent regulatory change to streamline training requirements. We are also exploring ways to increase transparency and provide beneficiaries with information on enforcement actions and plan performance. Medicare Advantage provides beneficiaries with a valuable choice, and the potential for Medicare Advantage in Part D has never been greater. Thank you for joining us for today's conference. I hope you enjoy the afternoon sessions. I hope the information you received today is valuable to you, and that you will continue to provide us feedback as needed.
Thank you, Demetrius, for sharing that valuable information with us today. We will now be taking our lunch break, and we will begin sessions promptly this afternoon at 12:30 p.m. For our in-person guests, please visit the cafeteria located downstairs. If you pre-ordered lunch, you can pick it up at the Jasmine Cafe, which is right outside of the cafeteria. Enjoy your lunch.